Hello family, hello friends. This is Dr. T and welcome to Clinical Medicine. So guys, we are continuing with our discussion on antihypertensives. In this video, I'm gonna be specifically be talking about calcium channel blockers. So please, before you can come and watch this video, please make sure to watch the first two videos that I'm just gonna leave. I'm gonna leave the two links on the comment section to those two videos. They are just introductory videos. So I did an introduction so that we can sort of like understand um, a little bit broader about antihypertensives before we can actually dig into a specific class or specific family of antihypertensives. But quickly, I'm just gonna repeat this. So what we said is that BP is equals to cardiac output multiplied by the peripheral resistance. And we said that we're going to be looking at different classes of drugs that can be used to treat hypertension. And we said that cardiac output, we know it's stroke volume multiplied by the heart rate, right? And stroke volume is determined by preload contractility and afterload, right? That's what we said. So I don't want to repeat what I said in the previous videos, but I'm gonna come here specifically and talk about conductility. The drugs that we can use or that we use to decrease conductility, because if you decrease conductility, you decrease stroke volume, decrease cardiac output, and decrease BP, right? So the drugs that we use, they're called calcium channel blockers or calcium channel antagonists, right? So now it's important to know, how do these drugs execute their antihypertensive function. So we need to understand that. But unfortunately, for us to understand how these drugs work, we need to revisit some basic anatomy and physiology. And please guys, bear with me. I cannot explain calcium channel blockers nicely if I don't go back to the basics, the basic anatomy and physiology, and talking about resting membrane potential, threshold potential, all those things. Remember, my channel is more about clinical medicine. I'm not a big fan of deep physiology, deep anatomy. That's not the purpose of my channel. But whenever I revisit some anatomy or physiology, some deep physiology, just understand that it's because there's a clinical correlation, right? So let's jump in and do it. So friends, please continue to support, like, subscribe, comment, and share. So if we go back to the structure of the heart, so we've got something like this, and this is our left atrium, this is our right atrium, left ventricle, right ventricle, right? And we know that within the right atrium, just inferior to the inferior vena cava, lies a special structure called the SA node. And almost at the floor of that, more on the side, lies the AV node. And right there we've got our His bundle or bundle His of His, and then we've got our left bundle branch and our right right bundle branch there. And because the right atrium, that's when the initiation of depolarization starts. But we know that when the right atrium contracts, the left has got to contract as well. So how does the action potential get to the left atrium? It's through the Bachmann's bundle. And also, if action potentials are going to move from the SA node to the AV node, what structures link, or what conduction fibers link the two? They are called the internodal fibers, right? Let's just label. This is the SA node. This is the AV node. Internodal fibers. This is the his bundle. This is the left bundle branch, and this is the right. And we know that there are small branches that actually penetrates the cardiomyocytes. They are called your Purkinje fibers. Right? So our action potentials, they originate from the SA node normally. That's where they are initiated. That I say normally because that's when you have got a functioning conduction system. But in the event whereby the SA node fails, you know that the AV node will take over, right? And if the AV node fails as well, the Purkinje fibers, they take over. That's when you've got some kind of conduction abnormalities. But normally everything starts in the SA node. So the heart is able to trigger its own contraction via the AV node. So the AV node has got what is called an automaticity, which means that the SA node can initiate its own depolarization, its own action potentials, and then contraction of the cardiomyocytes occurs. So you don't need, unlike the remember, if this is a skeletal muscle, a skeletal muscle depends on the motor nerve to actually contract. You know those this is the neuromuscular junction. So those acetylcholine will be released when the action potential is arrived at the end bulb, and then the acetylcholine is gonna attach or bind to its nicotinic receptors of the muscle or on the muscle, and then the muscle will contract. That's different with the heart. It's different. The heart is able to initiate its own action potentials and contract. This is one of the things that usually confuses people. So we say automaticity is the heart's ability to initiate initiate action potentials to depolarize on its own and contraction occurs, right? But the autonomic nervous system is able to influence at what rate is this done. The parasympathetic can decrease and the sympathetic can actually increase at what rate this is all done, but still it doesn't cause depolarization as you would expect. Like I explained, with the neuromuscular junction, the motor nerve comes in with an action potential and cause depolarization of the muscle, then the muscle contracts. It's different with the heart. There is no actual extrinsic really input that initiates action potentials. That's what automaticity is all about. Okay, now the SA node is a group of cells. It's a group of cells, just a bunch of cells that, very important, that are connected to each other via gap junctions. Gap junctions. Gap junctions are like a passageway for stuff to move from the cytoplasm of one cell to the cytoplasm of another cell. In this case, the movement of ions from one cytoplasm from one cytoplasm of another cell to the cytoplasm of another cell makes depolarization to actually spread from one cell to another. It makes an action potential to actually move like a wave and affect all the SA node cells, even if a few cells initiated the depolarization, but the wave is going to affect all of them, right? So the gap junctions are very, very important. Now, this action potential that has been initiated in the SA node is going to move to the AV node, and oh, I forgot to label the Bachmann's bundle. Bachmann's bundle. So that depolarization, that wave of depolarization will start from a few cells, spread to all the SA node cells, and then spread outside to the outside of the SA node via the conduction system to the AV node, to the atria via the Bachmann's bundle, right? Okay. Now, how does all of this happen? If we can take one of the things that we have to understand is that let me just use a different marker. All cells, because of the distribution of ions between the extracellular space and the intracellular, so there's always some kind of a potential difference. So the inside of the cell is more negative and the outside is more positive. So between the outside and the inside, there's a potential difference, right? So now these cells, they are very unstable. The nodal cells, they are very their action potential, their resting membrane potential is very, very, very unstable. So they can, it's easy for them to actually depolarize and cause an action potential. And they don't need a lot of convincing, basically. They don't need a lot of convincing to actually depolarize, if you can think of it, of it, of, 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 These nodal cells, maybe it's important to also mention that when it comes to the tissue, the types of tissue that we find in the heart, there are two types of tissue that we find in the heart. We've got the contractile and the non-contractile. The contractile is the cardiomyocytes. The non-contractile is your pacemaker cells, your nodal cells. And the main job, responsibility, is to initiate action potentials. So it's the conduction system. Initiate action potentials, propel them to the contractile cells. For a cardiomyocyte to contract depends on the input from the non-contractile cells. So these nodal cells, they have to depolarize in order to generate an action potential that will be propelled through the conduction system to the contractile cells. That's when now we can see contractility. Remember, calcium channel blockers, what they do, remember we said contractility, right? So we said that if we can decrease contractility, we can decrease stroke volume, decrease cardiac output, and then decrease BP. So what we don't want when we give calcium channel blockers, we want to prevent the cardiomyocytes from contracting. But how are we going to do that? That's what we are trying to answer in this video. Okay, let's come back to the nodal cells. So what happens is that the nodal cells, they've got leaky sodium channels. They are called funny sodium channels. Funny sodium channels. These funny sodium channels, they just keep allowing sodium to get into the nodal cells. If we can make a graph of that, so the resting membrane potential of nodal cells is about minus, remember here you've got, let's say here you've got 0, then this is the positive, and then this is the negative. So the negative, the resting membrane potential, what is the resting membrane potential? A resting membrane potential is the voltage at which cells are at rest. They are not contracting. To put it easy. Okay, so the resting membrane potential of nodal cells is about negative 60, minus 60. So these cells will sit there because they've got these channels, these funny sodium channels that constantly allow positive sodium ions to come in. They will have that dip. They are not, if you compare with the cardiomyocytes, which we're going to draw now, the cardiomyocytes, if you were to make their graph, the resting membrane potential is minus 90. So if this is minus 90, so for the cardiomyocytes, it's like this. But here, because there are no channels opened here, there are no leaky sodium channels there. But for these ones, there are leaky sodium channels, the funny sodium channels. So they allow sodium to come in. As the sodium comes in, close to threshold potential, those sodium channels, they take the membrane from the resting state and push it towards the threshold potential. When it's very close to threshold potential, that triggers calcium channels to open, specifically the T-type calcium channels. Very important, guys. The T-type calcium channels. Those T-type calcium channels will cause an influx of calcium. Remember, a resting membrane potential, the inside of the cell is negative. But now once you allow sodium to come in and allow calcium to also come in, both of them, they carry positive charges. You are neutralizing the inside and pushing now the membrane potential towards positive. So what's going to happen, you're going to get a step now. Because of those calcium channels that are opened, you get a depolarization. And those T-type calcium channels, they also cause other types of calcium channels to open, the L-type calcium channels. The L-type calcium channels, which allow more calcium to enter as well. Those ones are there. These are the T-type, these are the L-type. Right? Right now, your nodal cell, be it an AV node or an SA node, has actually depolarized now because it's more positive because of these three channels that allow cat ions to come in, right? What is important, guys, that you must also keep in mind is that when the cells are at rest, they have what is called a resting membrane potential. Nothing is happening there. Most channels are closed. But once you get positive ions coming into the cell, you are going to push this resting membrane potential to a threshold potential. A threshold potential. As long as you have a resting membrane potential and you are just getting a few positive ions coming in, as long as those positive ions are not a lot, you won't get to a threshold potential. And if you do get to a threshold potential, you are gonna move to depolarization. Depolarization. Once you get to depolarization, remember, a threshold potential, once you get to a threshold potential, there's no going back. But as long as you don't get to a threshold potential, you can still continue resting. A cell can still continue to rest and not depolarize. But once you reach a threshold potential, there's no going back. The cell is gonna go on and depolarize. But we are not discussing this for fun. Once you get to depolarization, this is when now you can actually trigger a contraction. Right? That's how you move, right? So now, okay. So guys, I don't want long videos. So I'm gonna stop now and I'm gonna stop now and make another video where I'm gonna take it from here going forward. Thank you guys for watching.